Okay, so I am going to start with a little bit of revision. The aim of today's topic is to give you an introduction to standardization of nomenclature and terminology. This is the standard terminology that we are going to use throughout the course. It's also very important because from our perspective, it is pretty much the standard that's used across most of Europe and by most of our Chinese counterparts with a few modifications. But more importantly, when you start reporting, it's quite crucial that you are using, I would say, a standard terminology, because that standard terminology means that you can report in a uniform, consistent manner with everybody kind of understanding what the other person's trying to say. And the danger of kind of using different kinds of terminologies between departments, especially when you're trying to do reporting. And a good example is when I was in Southampton, our PICU colleagues would report in a slightly different way to how we used to report from a neonatal perspective. And I think, that would often be a source of confusion. So I think what I'm going to do is just refresh a little bit about what we've done so far very quickly. Now, I'm going to start with the A lines again to kind of say that we identify A lines as horizontal parallel lines, which are basically a reflection of aeration in the lung. But what they basically reflect is reverberation artifact of the pleura. So you have, I would say, uh, an ultrasound machine throwing waves which are coming down. And as they come down, they cause reverberation in the pleura, which is seen in green over here, which basically then causes further reverberation down and produces these horizontal lines. And it's these horizontal lines that we call A lines, and they usually reflect aeration of the lung. Uh, just occasionally, you'll get an A-line profile with a pneumothorax as well, and we'll talk about that in more detail. But I think from my perspective, what's quite crucial is that we all know the difference between A lines and B lines. Uh, just moving forwards, again, just to give you an idea of what A lines actually look like. So this is normal lung profile with A lines in parallel, and you can see how they're normally equidistant to each other, and then they tend to become attenuated. So they attenuate as we move down. But again, what I'd say is that if you can see, uh, I would say pleura sliding, which you can see at the top over here with my cursor, along with parallel equidistant A lines in your entire lung fields. That's anterior, lateral, and posterior. Then essentially what you're dealing with, if you can see the batwing sign at the start, is normal lung, normally a rated lung. So can you see how I'm using standardized terminology to say that I would, in a normal lung, be able to see pleura visibly sliding. It would be normal in its architecture, in its thickness. I would be able to see equidistant A lines, and really I would be able to identify the batwing sign, and this would be the appearance that would be present in all lung areas for me to say that both lungs are well aerated. Guys, if you could just mute yourselves, those of you who've just come in, I'd be really grateful, so that we can avoid any distraction. Now, going forwards, what I'd say is that really when you have a normal lung which is well aerated, and on the left-hand side over here, you can see pleural that's sliding with an A profile with A lines that are kind of equidistant and becoming attenuated. If you put an M mode on, you'll get what is classically called a seashore sign. And the reason it's called a seashore sign is basically it resembles the waves with sand on the sea. So a very typical appearance. And again, this is really important because if you're worried about sliding and you can see a seashore sign, then in essence, you should have sliding there. Uh, this is what normal sliding looks like. So this is basically an adolescent, and you can see that the sliding, whilst present, is less prominent. But on the right-hand side, what you can classically see is very good sliding, again, with what are classical A-line profiles with well-aerated lung. So this is an A profile. What are B lines? So B lines basically reflect vertical reverberation artifacts. Why do we get them? So in essence, they were first demonstrated by Ziskin and their colleagues in 1982, and they reflect what I would say is interstitial fluid as it accumulates. And as it accumulates, B lines evolve. so that you'd have these vertical artifacts which then coalesce together to form compact B lines. Once the alveoli are full of fluid and these B lines coalesce, you get what is a white lung or an alveolar interstitial appearance. But just to give you an idea of how B lines are formed, so ultrasound waves will move forward. They will enter into tissue. And we know that between the alveoli, there are interstitial spaces. Now, these interstitial spaces have bubbles arranged as tetrahedrons in which the sound waves get trapped in red. And when they trap, they produce this vertical reverberation artifact that you can see in the blue arrows over here. And these classically are called B lines. Now, as the amount of fluid goes up, really what happens is the more the fluid, the thicker the B lines become. And I mean, this is just an example of how compact B lines are generated, in that you have a lot of interstitial fluid here, much more than as compared to the previous image. That might be because you have transient tachypnea of the newborn with lungs full of fluid. But these lines will be thicker, as you can see over here. And as they become more thick, eventually sometimes they can merge together and give you what is a complete white lung appearance with alveoli that's full of fluid. I'm basically going to skip the video here and just give you a little bit of an architectural appearance of what that looks like on lung. So again, this is classically on the right-hand side, uh, a B profile, a B line appearance. And the reason for that is you can see a rib here, so the bat wing, the pleural line. But more importantly, we say that once you can see more than 3 B lines per intercostal space in a neonate, that in essence becomes a B profile as opposed to an A profile. And the reason for that is you can see that these B lines, which are vertical reverberation artifacts, have broken the A lines down. They become thicker as the interstitial edema increases. And I mean, this is classically quite a thick B line. These are B lines. By definition, they should reach all the way to the bottom. And they must not be confused with Z lines. Now, this is a Z line. And Z line, again, is an artifact that basically reflects what is a reverberation artifact, but usually gets attenuated as you move down from the pleural line. This is not a true B line, and some people kind of refer to this as comet tails, and we'll talk about that. But so I'm going to throw it out to the audience, guys. What do you think about this lung? So this is a baby who is approximately 60 minutes old.
There's
If you could just
I can have a
identify
go.
yourself. Yeah, go for it. Yeah.
Hello, it's Naveen here.
Yeah.
I'm just trying. Means you can see the bat wing sign clearly. I've got two ribs and pleura. So it actually looks like you've got 4 ribs and pleura. There's good pleural sliding, and you can also see what looks like A line, at least A1, A2. But there is also in between you have B lines, which goes all the way down. So the only question I have is it 3 between intercostal space? Probably not. Eye of faith, I would say like 2 to 3 between intercostal space. But there is clearly you can A lines visualized and some B lines.
Beautiful. Anybody beg to disagree? Anybody want to put their hand up and say? So our workshops will involve a lot of interaction from you. So anybody?
Yeah, I
Go for it.
think I think the pleura here is thick, sliding, and there is a subpleuric consolidation also.
Okay. Okay. So okay, so we've got a slightly different point of view. So if I tell you that this is a term baby in air at 60 minutes with absolutely no signs of respiratory distress. Now, this is the most important aspect of interpretation. It's clinical correlation. So if this is a term baby with absolutely no respiratory distress, then this would reflect transitioning lung. And really, I think I would probably agree that you probably would have to convince yourself that there are subpleural consolidations. The reason why it may appear that some areas look brighter than the other is because of the image having a very high gain setting. And again, that's why image optimization is key. So in this image, the gain is quite high. And because the gain is quite high, that exaggerates the pleural thickness, but also makes you feel in some areas where you can typically see B lines originating, that there may be subpleural consolidations. Actually, if I adjust the gain settings, you'd probably be able to interpret this better. But I would agree with Naveen that actually what you've got is 4 rib spaces, at least 3 intercostal spaces clearly seen. I'm using a linear probe. This is the superficial part of the lung. I'm using a high frequency. I can clearly see a batwing sign, pleural sliding. And in each intercostal space, I would really struggle to convince myself I have more than 3 B lines. I do have aerated lungs with A lines. Now, if the baby had no signs of respiratory distress, then from my perspective, actually, I would interpret this as normal for this baby. And that's why clinical correlation is so important. But this is transitioning lung for you. Okay, so well done. Just gonna get my laser pointer to switch off. Now, just a few things that I would like to talk about. Again, just a revision of the fact that when you use older machines, you tend to get much better delineation of, I would say, in particular, A and B lines. And that's because newer machines tend to, I would say, reduce the amount of artifact that you can see. Now, this is quite important because really what you want from your perspective is not to say use a very high degree of speckle reduction, and you definitely want to turn your harmonics off if you've got a machine that has them on, because really the risk with using very high speckle reduction settings is you'll reduce the artifact. And the challenges that you then have is in being able to make an interpretation of the accurate nature of the profile. Now, what do compact B lines look like? So again, just a small kind of a series of slides that show a progression. So over here, what you can clearly see is 1 rib. It's an adult, so the second rib can't quite be seen, but take my word for it that this is 1 intercostal space. That's pleura, which is blurred, irregular. But more importantly, I think all of you will agree, that's more than 3 B lines per intercostal space. So by definition now, this is no longer an A profile. You can't see any A lines anyway. This is actually a B profile with more than three B lines per intercostal space. And really, if they merge further, you get these kind of compact lines that you can see over here that move all the way down, which are called compact B lines. And really, they can, when they're very preterm babies are seen, they can actually appear as columns where you might not even be able to differentiate easily. So you can just see a progression in how compact B lines can progress to the point where eventually, if you have both alveolar and interstitial edema, you will end up with white lungs. And these are just, again, as you can see on the right, you know, these are compact B lines. Now, the reason why you can't see them going to the bottom is because you're probably using a very high frequency with a focus that's at the level of the pleura. So actually, the deeper part of the lung is not well delineated. These are actually compact B lines. And if you reduce your frequency or shift the focus down to a second level, if you have 2 lines of focus, then you'd be able to see them much better. But actually, you can see how they merge to the point where you can't differentiate the compact B lines at all. And this is basically what you call as alveolar interstitial edema. It completely obscures all delineation to the point where you see a uniform kind of an appearance. And by definition, you should have AIS or a white lung appearance in more than 3 spaces. So R1, R2, R3 to call a large lobar segment whiteout. That is the definition by Jing Liu. But really, what I'd say is that if you have this appearance, pretty much R1, R2, R3, R4, you're really dealing with one entire lung that's white. Uh, on the other hand, as you progress, this is just another example where you can see subpleural consolidations with atelectasis. So it's again a white lung, but the difference between these two appearances, as I will discuss today, is this is a baby with transient tachypnea kind of picture, where the pleura is relatively blurred, smooth delineated, no subpleural consolidations. But here you can see subpleural consolidations, which differentiate RDS from TTN. you can see how both of them will have a whiteout, but with slightly different morphological appearance because of the presence of subpleural consolidations. But again, this is just the spectrum of how white lung might look. Again, just to give you a little bit of an idea, these are all examples of B profiles. So more than 3 B lines per intercostal space. Again, I'm losing the deeper part of my lung because I'm using a convex probe, which is using a frequency of about 3.6 megahertz to try and get to as deep a part of the lung as possible. So what I'd say is that really, in order to get this to a good depth, this is 14 centimeters. So the adults are using a frequency as low as 4. But really, what I would say to you is that you can get the same information with a curvilinear probe as you could get with a linear probe that you can see on the right-hand side. And this is quite important. As long as you know the differences in how you use your probes, you will be more successful in being able to make interpretations. These are more than 3 B lines per intercostal space. Again, if you look on the right-hand side, I would actually say that this space has only 2 B lines per intercostal space, and there is some aeration. You can see A lines, but which are breaking up. And really what this is reflecting on the right-hand side is the difference between inspiration and expiration. So when the baby inspires, you see what is an A profile appearing on that right-hand side. But when the baby expires, the interstitial edema is still present. So you can see 2 B lines come down to the bottom. Over here, what you can see again is B lines, but in the setting of what is a completely whiteout lung. So again, there's a significant amount of alveolar interstitial edema over here with some accentuated B lines. Now, by definition, the two on the left are B profiles. I would really want to know what the clinical history is of this baby if I was doing a scan, because if this baby has no respiratory distress, this could just reflect what I would say is transitioning lung. So you can just see the different kinds of B-line appearances. And this is what compact B-lines appear like when you use a sector probe. So if you used your cardiac probe, uh, again, you can see the challenges with using the cardiac probe is that the pleura is very poorly visualized because the sector probe tends to focus on a regional area. And the challenge then is it can make sliding and the appearance of the pleura look quite different. But I think all of us will agree that when you actually look at the profile that this appearance gives us, you can see these B lines which are coalesced together. And this is what compact B line appearance looks like if you're using a sector probe, to the point where as the edema, alveolar interstitial edema increases, you get what is I'd say a white lung appearance. So you can actually use different probes to give you the right information as long as you know their limitations. Now, just a quick revision of some very, very important terminology, because I need you to be able to kind of use that standard terminology. I want you all, as part of this course, to be using the same terminology. And really, what you need to understand is that comet tails, also called by some people as the ring down artifact, uh, basically are again, they are vertical artifacts, but which do not actually reach the bottom of the lung image. They often finish above it. And the reason for that is it's because of attenuation. Now, what is really important about being able to see comet tails are you must not count them as markers of interstitial edema. And it's really important that if you see them, that you tend to ignore them. But ignore them for interstitial edema. If they're present, they're really good to help you with actually visualizing lung sliding. I find them really useful because you can actually see them move from side to side. So if you're confused about sliding and you can see a comet tail moving, it usually indicates that sliding is present. So these are just examples of the comet tails that you can see. I'm not going to cover their physiology today, but in essence, very similar to B lines, there is, I would say, sound waves getting trapped in the tetrahedron. But the challenge is because there's not enough fluid, they tend to end well before they reach the end of the lung. Again, this is just a really nice comet tail appearance. And the reason I wanted to show you this particular image is you can classically see, again, a rib shadow. This is a rib shadow come in. So you see the bat wing, and you can see pleural sliding. Now, if there's confusion and you see these two comet tails moving the way they are, I mean, that pretty much confirms sliding, where you can pretty much see an A profile with A lines that are equidistant and gradually kind of decreasing. This is a normal lung. Even with the presence of a comet tail, we'd interpret it as that. Now, just for your knowledge, because some authors use the terminology of C lines, we've talked about A lines, B lines. Now, C lines basically reflect an area where the lung has retracted back from the parietal pleura. And when you see, say, a pleural effusion, basically that deeper margin that you see is referred to as a C line. It's not really a true line. And personally, between you and me, you can forget about it. It's not very, very important. E-lines, just for your knowledge. So the key takeaway in this image for me is I cannot see ribs and I cannot see a bat wing appearance. So really what has happened over here is this is where the pleura is, but you've got areas of air collection in subcutaneous tissue. Now, what we said is that air is a very good reflector. So when it reflects back, naturally, if it's in subcutaneous tissue, you might get these bright areas, but these lines that kind of originate above the level of the pleura, so that's the pleura, and normally if you had a B line, it would originate from the pleura and go down. This is actually originating above that level in the area of soft tissue. And if you see something like that, that looks like a comet tail, but occasionally they can actually move and be quite far into the lung, then that's actually what we would call as a B-line mimic or an E-line. Just be aware that they can erase A-lines, and that's why they can create confusion, but they can be a marker of subcutaneous emphysema. I'm going to be really honest with you. I mean, I've been scanning for 6 years. I've never seen it. So, but it's described in the literature, so I think it's important that we share it with you. But this is one of the B-line mimics that you will see very often, and it's a Z-line. And again, what it basically reflects is an artifact that takes its origin from the pleural line. It's a vertical bundle-shaped artifact, which does not erase the A-lines. So you can see A-lines over here at this particular point. This is quite a magnified image, but when you see it, it might appear as kind of a very wide comet tail if you see my hands. So rather than having that pinpoint comet tail, it appears quite wide. We have some images that I'll show you today where you can actually clearly see them. So again, just to be aware that Z lines do not reflect interstitial edema, and you just have to be careful. So if I see lots of Z lines in between two ribs, and I've got a baby who is in air with no signs of respiratory distress, really that's likely to be a B-line mimic rather than actually interstitial edema. Now, for normal lung, the protocol again, just before we start moving to the abnormal lung, is basically identifying the bat wing sign. Always remember, if you cannot identify ribs and a bat wing sign, especially if you are at the lower margins of the chest, laterally and anteriorly, be very careful, because really a stomach with air in it will also give you an A profile. And I have seen people sometimes get confused. They can't see sliding in that, and they confuse that with an pneumothorax. And it would be a disaster if you ended up putting a needle in that situation. I'm going to skip this slide because we've already done this. So we've talked about the seashore sign. We've talked about normal lung sliding. Again, this is just a comet tail that you can see with normal lung sliding. But what is very important is that when you lose lung sliding, then really you are in big trouble. Big trouble in the sense that there is something that's wrong over there. Now, folks, I want you to come up with the causes of absent lung sliding. So you can clearly see there's no lung sliding on the right over here. So everybody, what are the causes of absent lung sliding?
Pneumothorax.
Excellent. Sorry. So we
Collapse,
have
atelectasis.
beautiful. So complete collapse, lack of lung aeration. You won't see the pleura actually. and I will show it to you today because there's no air going into that area of the lung. So if there's no air going into the lung, you can't see. So complete collapse, atelectasis. What else?
Pneumonia, severe pneumonia.
Severe RDS.
Severe RDS with severe atelectasis, yes, you might not be able to see lung sliding because the pleural margin may not be visible.
Pleural fluid.
Yeah.
Pleural effusion.
Yeah, very good. So pleural effusion, visceral parietal pleura will have fluid in between, so you can't see sliding at all. You'll see a dark hypoechoic area. What else?
Pleural adhesion.
Really, really, really important. So I'm just giving you a feel for a baby with a pneumothorax who had in our setup a few years back where I was working, had a chylothorax which was drained multiple times. And we ended up, from our perspective, extubating the baby after starting octreotide, moved the chest drains. And after about a week or so, this baby developed acute respiratory distress. And on chest x-ray had a significant anterolateral pneumothorax, which was causing tension. So the baby was needled and had a chest drain put in, but with no improvement. And actually, the baby eventually passed away. What we realized on postmortem was that the lower half of the pleura, for where the previous chest drains had been put in, was completely adherent. And, again, from our perspective, unfortunately, because of that, the chest drain that was put in went straight into the lung. Now, that is why it's very crucial in situations where you might see the absence of lung sliding, that you very carefully try to differentiate whether the absence of lung sliding is associated with other signs of a pneumothorax on ultrasound. Because there may be situations where you've got paucity or absence of lung sliding that are explained by other clinical conditions, and pleural adhesion can be one of them. So if you've had previous chest drains in or any reason to believe that, just be a little bit cautious. So that's no lung sliding for you. Any questions so far? That's a very quick revision. Any questions that you have before we move forward to the next topic, which is very crucial?
If intubation deep to one lung, the other lung not sliding.
Yeah, so if you have a right main stem bronchus intubation, I'm going to show you an image of that today. Then really what happens is the right lower lobe collapses, but sometimes what happens is the entire left lobe collapses. So if the left lung is completely collapsed, then really you're not going to have any aeration of that lung. And if you don't have any aeration of that lung, you're not going to see very good sliding or no sliding at all. So again, those are some of the differentials. Any other questions?
Dr. Alok,
Yeah.
how do we differentiate coalescent B lines and compact B lines?
I wouldn't worry too much about that terminology. They're the same thing. They're
Okay.
pretty much the same thing. What I'd say is that by definition, when we talk about profiles that I'm going to talk about, I'll be able to explain it better. But I'd say that as they coalesce, if you can see them as columns, so again, just going back to go back quite a few slides actually. So really, this is the slide. Can you see how these are B lines individually, but they're starting to coalesce together? And these columns that you can see all the way to the bottom, these are what we call, I would say, compact B lines. So it's the appearance. They might be slightly smaller. They might be slightly bigger. So this is an immature baby with RDS, and you can see these columns are much wider as compared to as seen in this term baby over here. So I wouldn't worry too much about the terminology. They pretty much imply the same thing. Any other questions? Okay, so what we're going to talk about now is a very, very important concept for you for reporting, and that is called lung profiles. And really, this is from where we start the abnormal lung. So Daniel Lichtenstein has developed a protocol which is called the Blue Protocol. And that basically classifies lung profiles based on the appearance of, I would say, multiple areas of the lung. So the idea from our perspective is that you want to describe, and we want to describe a particular area of the lung. Now, we can give a very descriptive kind of a kind of a report, which kind of says, well, the first intercostal space and the second intercostal space, the gap between them shows less than 3 B lines with A lines, pleura that looks normal, sliding. And you could do that, and you could write that for virtually every intercostal space, and you'll just end up generating a lot of information. When you want to pass that information on, really, what you really want to give a person an idea of is what is happening in both the lungs, which is naturally quite a large, I would say sectorial area. So by describing those areas as profiles, you can mentally model and mentally map better. So if I basically come to you and say that I have a term baby who was admitted with mild respiratory distress, by the time we got him to the neonatal unit, the distress had settled. And I can see a batwing sign with pleural sliding in all areas with an A line profile in all areas, then that basically is called an A profile. And that in essence usually indicates that you have normal lung. Now, clearly, when Daniel Lichtenstein kind of spoke about it, there were pathologies in adults to which he linked these profiles. And not all these pathologies necessarily translate themselves into the presentations that babies have. But the terminology that he has developed can be used by us to try and explain what we think and how we describe the lung so that we're using the same language. So just to take you through the different profiles, an A profile is essentially well-aerated normal lung with sliding. And really, for any baby who has an A profile in all areas, you'd expect both lungs to be normal. As I said, a B profile, once you have more than 3 B lines entering in to the intercostal space, really for that space, and if there are multiple spaces, R1, R2, R3, R4, then really what you're talking about is transition from an A to a B profile. A C profile basically implies consolidation, which basically implies that you have no visible A lines. Usually, I would say some kind of a deep B profile, but with hepatization, that 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 kind of means that you've got a consolidation. And in adults only, Daniel Lichtenstein has described what is called an AB profile, which means that one lung has an A profile and the other lung has a B profile. Now, he links that to pneumonia. We do not use this terminology. We don't use it in neonates because there are very few clinical situations in which we'd normally describe it. Now, for all practical purposes, if you have an A profile but with no sliding, then that's called an A- profile. And similarly, if you have a B profile with no sliding, that's called a B- profile. And essentially what that reflects is an A- profile is a pneumothorax, and a B- profile could be significant atelectasis of the lung. And we're going to talk about all these profiles. So again, just to give you a pictorial example, an A profile, you will see normal batwing appearance, normal morphology of the pleura, sliding, an A attenuated profile of A lines that are equidistant parallel. And really, in a baby who's asymptomatic, if you see this in all regions, that's normal. But as soon as you see more than 3 B lines per intercostal space, as you can see here, we're transitioning to a B profile, and we build upon that. But if you start seeing an area which looks hepatized, dense, with irregular pleura, and then really what you're talking about is a consolidation profile or a C profile. So this is what they really look like, but really there's a little bit more depth to it. And this is quite important in that when you look at lung aeration, again, unfortunately for us, babies show transition. And that transition means that you could have a baby who starts in its mother's womb without any aeration, where all the oxygen and carbon dioxide is being managed through the placenta. And actually, for that baby, you're not going to get an A profile because his lungs are full of fluid. But as soon as he's born, really, from our perspective, you're going to get a transitional profile, which moves from this profile that you can see over here, where you can see, I would say, more than 3 B lines per intercostal space, with some aeration on the right side, to lung that has less than 3 B lines per intercostal space in all the lung regions, and to lung that then looks completely well aerated. So just moving clockwise, this is lung that has a lot of fluid in it, interstitial fluid. There's a little bit of a pleural effusion there that you can see as well. So this is a baby who, say, from our perspective, is transitioning, has then transitioned to aerated lung, to lung that's completely aerated. So you will have situations which are in between B and A profiles. Now, it's for you to define in your unit how you want to kind of what nomenclature you want to use. In my unit, we use the nomenclature transitional lung. We tend to avoid the use of AB profile. Some units like to use AB profile to kind of say that there's both A and B profile, as you would see with transient tachypnea of newborn. I would say that you really need to develop standardized definitions and a standardized approach to how you want to approach transitional lung. Because really in a baby who's asymptomatic, where I see this appearance with a lot of lung sparing, you know, for me, that would be normal for that age. That would be normal. And what I don't want is for people to kind of get confused and start thinking that if you have more than three B lines per intercostal space, that there's always something wrong with the baby. If it's a baby that's just been born, he is going to transition, and he may have more than 3 B lines per intercostal space. But as that improves, things will naturally get better. Now, again, this is just an example from our perspective of how you might find transition taking place. So this is well aerated lung. You can see A lines that are visible over here. You can see the odd B line that's moving to the bottom here, but these are actually comet tails. And really, this is where I would say that what you're really seeing at this particular point is on this left-hand side is Z lines. They're not true B lines. You can see how they diverge, and they can commonly be confused with B lines. And really what you have is you really have just one true B line over here with comet tails on the left-hand side. In the middle over here, what you can see is that you have a dominant B profile where you have more than 3 B lines per intercostal space to the point where they've actually coalesced over here. And this for me has now transitioned from what I would say is an A profile, which is what I'd call this, to a B profile. Further interstitial edema with alveolar edema, and they're now large quadrilaterals, as we describe them, these quads, these appearances of compact B lines. It's becoming so bad now that really this is evolving into AIS, and you can't see any A lines at all, but these large merged areas with quite thick and blurred pleura. And really now you can see white lung. And these are just two different examples of white lung that you can see at this particular point. So again, can you see how transition can take place? Now, if this was the same baby, and I told you that this is a preterm 24-weeker who's now coming to 10 days of age, whose ventilation is going up. Really, this was after surfactant. This is day 5, 6. This is day 8, 10. Then a real question that I would be asking myself is this baby evolving into chronic lung disease? But the other potential in this situation is whether the baby's got a duct with a significant left to right shunt, because that will give you this kind of progression. So you can see how important it is to use standardized terminology, but also standardized terminology in the context of lung progression and serial scanning. So really, if I was describing this report in the same baby, I might say that over the last 14 days, I've got a baby who's moved from well-aerated lung post-surfactant A profile to what is a complete whiteout with what is a dense B profile. So that gives a good description of the clinical course this baby's taken to your colleagues when they read your report. So that is why it's important. Now, again, just want to mention that we do not standardly use AB profile as is described in Daniel Lichtenstein's Blue Protocol, because they implied that one lung has an A profile and the other lung has a B profile, and it was usually indicative of pneumonia. But some colleagues I know like to use this concept when you have transitioning lung or transient tachypnea. Now, as you can see in this lower image over here, you've got an area of lung. So you've got the batwing sign, you've got pleura that looks slightly thick and blurred, but then you've got these A lines with an A profile with attenuation, very much adjacent to these compact B lines that you see at the bottom. Now, this is the left posterior lung, and this is classically what we call a double lung point of transitioning lung. Some people use the terminology AB profile. I would advise that you avoid it because it creates confusion with PICU and the adults. I would say that you describe this as either lung sparing, or you describe and say that, if this was a zone where you were looking at L5-6, that L5 looks well aerated, and L6 actually has a B profile. So A profile versus B profile adjacent to each other with a double lung point in between. And that'll give people more information with regards to the fact that if this is a baby that's getting better with respiratory distress, near term cesarean section, then actually this is a reflection of the transient tachypnea of the newborn. C profile, as I told you, is what we classically call consolidation profile. Okay, so anybody, can I get anybody to describe what they can see over here? So which view is this?
Horizontal.
Very good. So just, you cannot see a very nice batwing sign over here because the batwing sign is best seen when you have your probe in this plane. But if you're looking at each individual intercostal space, then really each individual intercostal space, you're going in between the intercostal spaces. So really, this is really what you're seeing is, I would say, rib. And below that, what you're seeing is an area of very irregular pleura, which is broken in areas to the point where there's consolidation deep down. But rather than seeing, I would say, any kind of A lines, you have a B profile with really what is, I would say, pretty much interstitial edema. But then you have this area that looks very much like broken down tissue. So this is a tissue sign. You've got these static kind of shadows there. They're called static air bronchograms. They disappear and appear, as you can see over here. And this is classically what we call consolidation profile and is reflective of a consolidation. Now, naturally, if this is a baby who has a CRP of 60, whose FiO2 is going up, then this could be mnemonic. And we'll talk about how you differentiate the two tomorrow. But more importantly, I mean, if this is an X23-weeker who's 37 weeks of gestation, who has bulbar discoordination and has aspirated, then this could be a consolidation secondary to aspiration. So clinical correlation is very, very key. This is opposed to what we call is atelectasis. And again, we'll talk about this in much more detail. So here you can see a pleural margin. You can see a pleural margin. You can't see the pleural margin over here. So there's an element of atelectasis over here, but really it's very irregular. So because of this irregularity, I'd be very worried there's a mnemonic kind of a consolidation over here. Whereas on the right-hand side, I've got this really big upper zone. So this is right anterior mid that you can see over here. This is technically R1, and we're moving towards R2. And really, upper lobe of R1, rather than seeing an A profile, as you can see, well aerated lung over here. So just describing it to you in detail, I've got a batwing sign, I've got ribs, I can see 1, 2, 3 intercostal spaces. I can see pleura, I can see pleural sliding because I can see these comet tails that are moving. And then I've got these A lines that slightly attenuate. So I've got really well aerated R2. But when I look at R1, I can't see a pleural line. I can definitely make a batwing there, the two ribs, but there's no pleura. What's happened over here? And then I've got this really large area that looks pretty dense, that looks like tissue, like liver. And it's got this kind of starry scarred appearance. It's got these small areas that appear and disappear, which are called kind of, I would say, static air bronchograms. So this is atelectasis. Now you can differentiate on this by using Doppler, and I'll come to that. But really, these are just different examples of consolidation and atelectasis, which represent a C profile. So this is a baby where I have intubated the right main bronchus, and the baby's lost its right upper lobe. So very good examples here of what the C profile actually looks like. What is the A dash profile? So an A' profile is classically seen when you have a pneumothorax. And really what it reflects again is, so you can see the batwing appearance is you've got pleura, no sliding in this. You've got mirror image artifact, which is called a truck sign. You've got an A profile, which basically you are able to see. And that's because naturally, from your perspective, while there's air between the pleura, uh, the proximal element of the pleura, sound waves will still bounce off it and create horizontal reverberation artifacts. So what you will not be able to see from your perspective is B-lines at all or comet tails at all. So if you see this and you get this kind of appearance, which is what is called an M-mode barcode appearance, then really what you're looking for is the lung point. Really, what you're trying to delineate is how severe this pneumothorax is. But by terminology, we call this an A' profile. Now, this is important because for a baby who's supine, air tends to rise anterolaterally. So you're really going to see an A' profile anterolaterally unless you have a loculated air collection. I'm not going to talk about that today. It's not common. Now, really, what is important from your perspective is that whenever you have air and an A' profile, you will obviously have air that will accumulate. Now, if it's a small pneumothorax, you'll have anterior air, but lung laterally will be clearly visible. So because of that, you will have a point of transition where when you use M mode, you have normal lung and a pneumothorax. And that area of transition is what we call the lung point. And I will cover that in a little bit more detail, but I'm just giving you an idea of the fact that you have to have a barcode sign on M mode for the diagnosis of a pneumothorax, but there will be a transition point where normal lung, and just to give you an example of the transition point, so I'm just gonna go back a few slides. Okay, so this is normal lung sliding for you. And if you see normal lung sliding throughout, then you will get a seashore sign. But if you have a pneumothorax, there will be an area where you're not able to see lung sliding. And that area will transition with an area of lung sliding. Now, that transitional point is basically what we call a lung point. I just want to show you this image because it's very important and very nice. So can you see how you can see sliding in this area and you can see no sliding in that area? And that's the transition point for where air is versus normal lung. And that area is called the lung point. Now, to quantify a pneumothorax, you should be able to say where the lung point is. Now, in an anterolateral pneumothorax, if you have air that's accumulating moving all the way to the posterior axillary line, that's a pneumothorax that's getting worse. Whereas air that's just loculated anteriorly, if you can see the lung point at the anterior axillary line, well, that's just anterior air as you'd see in a small anterior pneumothorax. So you can actually use the lung point to quantify how severe your pneumothorax actually is. So again, just an example of what the barcode sign looks like on M mode. So there's no sliding. It's very clearly visible to you over here that there's no sliding. But really you get this appearance of an absence of shimmering of the pleura, which then gives you this barcode sign. Now just remember, if you have not got good contact of your probe with the skin, you can end up with a barcode sign. And there are differentials of the barcode sign, which are called this pseudo-bleb sign. We'll talk about them when we talk about pneumothorax in detail. But when you reach your lung point, if you're tracing it, you will see alternating seashore with barcode sign. So that's another way of finding your lung point. You can put M mode on and you can actually see an alternating seashore and a barcode sign once you've reached that. And we'll see a lot of cases. When we do review, we'll be seeing a lot of cases. Now, what is a B' profile? So as I explained to you when we talked about the C profile, you can see sliding over here. Okay. Now, naturally, this is an area of atelectasis. So there's no pleura because there's no air coming in. The pleura is not established. But just occasionally, what might happen is you might have an area of lung which is severely consolidated and also has atelectasis. Now, because there's significant atelectasis over here in this region, actually, you're not able to see very good sliding. And you can see how the pleura is appearing and disappearing. I'll give you a bottle of champagne if you can tell me why. Anybody? So on the left-hand side, anybody want to have a go? Why is the pleura appearing and disappearing? Nobody? Okay. So this is the same baby who was intubated right main bronchus, and we had complete atelectasis. Now we've pulled the tube back and there is some aeration. So when the ventilator gives its inspiratory phase, air enters in and the pleural line is established. But in the expiratory phase, we still haven't recruited the entire lung. So actually, what you're seeing is slight improvement. You can also see that there are fewer static air bronchograms at this particular point because the lung is starting to actually re-expand. So again, really, this is a really good example of how lung ultrasound can help you make, I would say, decisions about whether you need to recruit, because here we've established the pleural line after having pulled the tube back because this area is well aerated. This is simply before and this is after. So on the right hand side is before the tube was pulled back and on the left hand side is after. But really what you can see here is that the pleura is not moving. And that's because we just don't have enough aeration to actually produce consistent sliding. So this is classically what you call a B- profile. In this situation, you can't see pleura at all. So again, this is, you've got a lot of interstitial edema over here with static air bronchograms, no pleura. So this is kind of another example of a B- profile where you see there's no description of a C- profile. I mean, some people would say, well, that's tissue sign with a C profile and no pleura visible. I think what I would say is stick to the standard descriptions, standardize what you have to for your unit in your unit protocol, and use that terminology. And if you commonly use that terminology, you will be commonly able to describe things in a manner that you're able to understand better. Any questions? Any confusions about any of the described profiles?
Dr. Alec, for the previous slide, the one, yes, the image on the right showing the apical atelectasis or collapse. The transverse whitish line that is appearing at the atelectatic area, is this considered as a Z line? I'm a bit
No.
confused.
This is basically, we've pulled the tube back and I have been doing serial ultrasound. This is consolidation. This is atelectasis, no pleural line, static air bronchogram, strapped air, no air reaching the pleural margin. So because there's no air actually inflating that area of the lung, you can't see pleura at all. After a period of time, what has happened is you now have better aeration. So this is just an area of consolidation of the lung that's moved up because now we're recruiting lung to a point where we can now establish air. That's not a Z line.
Okay.
That's consolidation. This is like a tissue sign, a big tissue sign.
Okay, got it. Thank you.
Any other questions? Yeah.
Dr.
Just
Alok,
one
please.
question. Sorry, I'll let you go, Dr. Ashraf.
Please, if there is along the pleura micro subpleural consolidation, it is also called the C profile. Well, there's no C profile at this time.
No. When you look at RDS and you describe subpleural consolidations, we do not call it a C profile. It is almost always a B profile with subpleural consolidations. So that is a completely different terminology that we describe with respiratory distress. I'll come to that.
Just one query.
Yeah,
Look, in the next
yeah.
slide, it says A- profile has lung pleural sliding present, but I thought A- profile
Absent. My apologies.
absent as well. That
That's a
should be-
mistake. Yeah, very
Yeah.
sharp. Very sharp. Okay. So I need to make that change. Well done. Well done. It's always absent. An A- profile and a B- profile. With B-, just remember, it may be reduced to the point where it's not visible. But for an A- profile, you're talking about a pneumothorax, you must not
Yeah.
see lung sliding. Any other questions? Okay, now I'm going to end this bit of the presentation before we move into proper lung pathology by quickly talking about lung transition. Now, as I've mentioned to you and as well described, and I will share Blank's article with you today, is that really what is normal for a baby has to be dealt with based on the baby's clinical presentation, age of presentation, and symptoms. Now, this is a baby in the mother's womb. Naturally, this lung is not going to have any aeration. It's full of fluid. So if it doesn't have any aeration, and this is obviously captured just as soon as the baby's born, prior to initiating any breathing at all, there's no air in the lung. So you're not going to see. So this is the batwing sign. This is pleura. This is acoustic kind of artifact second behind the ribs. So no air means no pleural line because no air is entering the lung. No air means no A lines, which kind of means lungs that are completely collapsed and consolidated because they're full of fluid. The alveoli are full of fluid. So you get this kind of hepatized appearance. So this is kind of what you would describe as a C profile. But as soon as the baby starts taking breaths, as I explained to you in this previous image, as air enters, and as you can see, as air enters and lung gets recruited, the alveoli gets recruited and you start seeing the establishment of pleura. So really here we can't quite see any pleura, but we can see now that there's alveolar recruitment. It's lung that's still consolidated, that's starting to recruit because air is starting to enter it. You've got these areas of static air trap bronchograms. So air trapped in the bronchial tree, which is a bright reflector. Now, as the baby breathes and you have more lung, you get a pleural line established. But what we also know is that the interstitium is still full of fluid. Now, because the interstitium is still full of fluid, we're going to get compact B lines. And as the baby breathes more and air enters, and you get this air in the alveoli versus these B lines, then really this is a reflection of better aeration, or what I mentioned to you, some people describe as a double lung point, lung spared areas, or an AB profile. And then finally, what you're going to end up with is fully aerated lung, which basically has been described by by Blank CMS type 3. This is normal well aerated lung. There's pleural sliding over here. So this is the transition that babies will normally go through. And you have to be very cautious because you might have a baby who has prolonged rupture of membranes, who has group B strep, who has significant respiratory distress. And really, if you see persistent hepatization when a baby has well aerated lung, so a simple example is this situation over here. So let's say this baby is 6 hours old. Well, the rest of the lung is well aerated, but actually this baby has significant respiratory distress, and I see a C profile consolidation with static air bronchograms. Now, this could be a pneumonia. This could be a congenital pneumonia. So again, clinical correlation is absolutely key. On the other hand, really, if I'm seeing this kind of a profile where lungs are still quite collapsed, atelectatic with a tissue profile kind of at birth, in a baby who's vigorous and crying, if I've done this at 30 minutes and this baby's FiO2 is improving and it's a cesarean section, I need to give him more time to recruit. I might well decide to screen start antibiotics. But if this then transitions in this manner in 2 or 3 hours, then really your retrospective diagnosis in this particular situation would be normal lung transition or transient tachypnea of newborn. And that's why clinical correlation is key. And that's why sometimes you need to do serial ultrasounds. Because if you assume that this is a mnemonic presentation because you've done an early scan, then you might be making the wrong diagnosis. Might end up treating this baby for 36 hours pending cultures, but really the diagnosis that you'd make would be very different. So you need to know the normal history of lung transition at birth. Okay. Just want to acknowledge a few colleagues who've helped lend slides. Wanted to acknowledge Douglas Blank again for his article, which I think is absolutely amazing. I'll share it with you. It has some really nice videos that you can use to watch, but we have his permission. So any questions? Just while I switch presentations.
The type from type O to type A, type 3. how duration for how long? How long duration to take
Okay,
from 0 to
that's
3?
a lovely question. Blank's article says that you can actually have it in 10 minutes. So it may take 10 minutes for you to move from, you know, 0.5 to stage 3. Pretty much, I'm letting you know that I've done lung ultrasounds at 20 minutes where I've had fully aerated lungs with A profiles in all segments. In a baby who was grunting at birth, who's just come to the neonatal unit 20 minutes later after having a cuddle with mum, and actually has got A profiles everywhere. So transition can be very, very quick, as quickly as 10 minutes. Transition can be quite delayed. And this is really important when we talk about RDS, but I'll come to that. Any other questions? Okay, now we're going to finish off in the next half an hour by talking about abnormal lung profiles and abnormal lungs. We're also going to talk about a few of the important lung signs that you probably haven't kind of had described so far. Now, one of them is lung pulse. Now, lung pulse basically is, I would say, the transmission of movements and beating of the heart to an area of lung that becomes visible. And the reason that we often don't see lung pulse is because you have air coming in and out of the lungs. So sliding is more apparent than lung pulse. But if you're in a situation where you have a complete consolidation collapse of a particular area, there's not going to be any air. So if there's not any air in that, you get a B dash profile, no sliding, but really you could still get transmitted pulsations of the heart in that region. And those transmitted pulsations of the heart may confuse you. And you might think, well, there's sliding present. And you have to be extremely careful. So really, the way it reflects is when you do M mode is this small area that we call them T lines or transmitted heartbeat. So you can see these small areas of edges that you see that come through. So again, if you're confused, you're worried that you have an area like that, you can put some M mode on and see. But just an example here. So we're looking at this image on the left-hand side. So anybody want to have a go? Is that lung pulse or lung sliding?
In the right,
Lung
the,
sliding. Lung sliding.
Okay, beautiful. So is there lung pulse visible in this slide at all? There is. So this is lung sliding. These are the comet tails. They're moving. Can you see? But can you see what's happening to the, what is that? Anybody?
Yeah.
What is this? Anybody?
Consolidation.
Okay. Could be. So can you see a batwing sign?
No.
Very good. So I can't see a batwing sign. I need to go higher up, but actually we're well above the level of the pleura. That's a vessel. It's thymus. So just to give you an idea, thymus can really confuse you with a C dash profile, a C profile, a consolidation profile. But can you see how it's moving? This is lung pulse. It's transmitted heartbeat as opposed to sliding. So in the thymic shadow, you actually see what is lung pulse. So just on the left-hand side, I'm going to play it for you again. This is lung pulse. This is sliding. Very well visible over here. So this is lung pulse. It's beats of the heart. Anybody want to tell me? This is a heart rate that's about 80 to 90 because it's adult. This is sliding. Now, the best way to kind of look at them is, that's why I would say comet tails are so helpful, because if you see comet tails, you can see the movement to and fro. Again, over here, you can see comet tails moving to and fro. Over here, your comet tails don't move, they bounce. So this is basically lung pulse for you. It's very, very obvious in babies because often the heart rate's much higher. This is because this is an adult. But very important, just again, the concept of a spared area. So what is a spared area? So as I told you that in babies with delayed transition or transient tachypnea newborn, you will have areas of aeration So A profile alongside areas of B profile, which can vary. It might be compact B lines, as you can see over here. Again, this is a compact B line that you can see over here. This is well aerated, kind of A profile. If the pleura is sliding, these spared areas basically reflect areas of the lung that are getting aerated. Now, what we know that if you read Blank's article, the anterolateral parts of the lungs and the upper lobes tend to aerate much more quickly as compared to, I would say, the lower lobes. And if the baby's supine, then the posterior parts of the lungs tend to aerate even, I would say, more slowly. So often what you'll find is you'll start seeing these spared areas, or what you call as a double lung point, quite early on when there's mild TTN. But when there's very severe TTN, I would say that in particular, this anterior aeration will suffer and you'll see less lung spared areas. So just be careful that because you don't see a double lung point, you see a complete whiteout lung early on, you decide that the baby might not have transintercypnia of newborn. It's really important that you serially scan and you look at the clinical course of the baby. So if the baby after 4 hours has this appearance with double lung points and is clinically improving with a reducing FiO2 and normal gases, then really, provided there are no other features of consolidation infection, then really spared areas are usually a feature of transitioning lung or transintercypnia of newborn, as opposed to RDS, where you will tend to have uniform lung disease prior to giving surfactant. This is really, really important. The early articles by Corsini, the early articles by the Chinese, by Jingliu, described spared areas or double lung points as pathognomonic of TTNB. They are not pathognomonic of TTNB. And the reason is because you give surfactant to babies. And if you give surfactant to babies, you will have better aeration and you will have double lung points. You'll also have babies who have mild surfactant deficiency who are getting better. Naturally, their lungs will also aerate. With so many babies who we manage with CPAP these days who get away without surfactant, they will also show double lung points. So they're not necessarily pathognomonic of transintercypnia of newborn, but following clinical course, they give you good information. Now, when you have severe TTN, just to give you an idea, this is how severe TTN is gradually improving. And spared areas may not necessarily reflect as AA lines alone. You might just have what is a complete whiteout evolving into what are these compact B lines to a B profile. So this is actually a baby who's improving with a B profile. Now, if he's clinically improving and his CRP is normal and this is a cesarean, this is also an example of what might reflect, I would say, transintercypnia of newborn. It's just it might take longer. Maybe this baby is going to take 48 to 72 hours to get better because it's quite severe. So again, really important. We've talked about the comet tail artifact. Now we're going to talk a little bit about pathology. Now, what is the C profile or consolidation and why does it happen? Now, quite crucially, I would say that if you look at normal lung architecture, you have got bronchioles, which basically end up with the alveolar tree. And in between the bronchioles, basically you have interstitial space, these interstitial spaces. These interstitial spaces have pulmonary veins and lymphatics. And really, when you have fluid in the interstitial space, you're going to get more B lines in a B profile. You get aeration of these particular areas with the alveoli. The alveoli expand, then these interstitial spaces get squeezed, and you get transition of a B profile to an A profile, which is well aerated lung. But if you have fluid in the bronchial tree because of infection, pus, pulmonary hemorrhage, or a variety of other reasons, we've got a right mainstem bronchus intubation, so no air is actually entering these areas, then what is going to happen is gradually you'll have fluid and exudate accumulate, which will block this area off. Now, naturally, air won't be able to enter. And if that is the case, what is going to happen is these alveoli will collapse. Now, you may have an element of inflammatory response with interstitial edema, but what you're classically going to get is what we classically call as a tissue sign. So when we talk about tissue sign, we talk about the tissue appearing like liver, hepatized. So we know that liver, when it is hepatized, has this kind of uniform look, which looks like tissue. And this classically is what we call a consolidation. Now, I'm not going to get into the difference between consolidation and atelectasis today. That is a whole new session on its own. But just remember, few features of a consolidation. I told you the pleura may be abnormal. It might be absent, especially if you have atelectasis with it. There may be reduced sliding, as you can see over here. It's barely visible. You can see sliding over there. Can you see those comet tails moving really nicely? But over here, I can't see sliding at all. I can just see pleura appearing and disappearing. I've got this hepatized tissue, which basically looks like liver. I've got these small bright pinpoint areas which appear and disappear. These are basically trapped air, which are quite bright. They're called static air bronchograms. Occasionally, if there's infection, I can get what is called a shred sign, and I'll talk about that. But these are just different examples of tissue hepatization. So that is liver, as you can see, and it has a very kind of a uniform tissue-like appearance. That's a blood vessel within it. So you can see this liver-like appearance over here with trapped air, with a lot of, I would say, static air bronchograms. Pleura is completely gone over here. So really, this is what you'd classically call as a C profile or a consolidation. The idea is that you've kind of got a tissue-like appearance, and really, depending on how severe it is, you can end up with consolidations in a small area of the lung. So this is just the right upper lobe, which is consolidated over here. The pleura is actually well established because there is an element of aeration here, but the A lines are completely, I would say, broken down in this area. And you've got quite a significant B profile, which is starting to look tissue-like. What is this? Anybody?
Thymus.
Yeah,
Thymus?
it is thymus. The reason I'm mentioning it is, can you see how easy it is to get confused? This is not thymus. This is a right upper lobe consolidation. The reason I know that is because of the batwing sign. I've got two ribs. I've got no pleura here. But actually, when I go into the next slide, what happens is I've got a rib here. You go higher up, you can't see a rib. This is thymus. There's also a blood vessel within it. So this is actually thymus. There is a small consolidation just there with a dynamic air bronchogram. It's not very nicely visible. But what is very important is that if this involves the whole of the lung, as can be the case with pneumonia, then really this is the appearance you get. So aerated lung, upper lobe, and then you have the whole of the lung here, consolidated tissue-like pleura that's completely destroyed with a very irregular margin. This irregular margin is what we call a shred sign. So you can see it over here. That's shred sign. This is shred sign. And shred sign is a marker that there might be an element of mnemonic presentation or infection here. If I have a high CRP, I'd really be thinking that this consolidation is mnemonic or infective in etiology, as opposed to this consolidation, which is actually because I've got to tube down the right main bronchus. So very important from your perspective that you clinically correlate again, and that you're looking at this in the right context. I mean, this is virtually the whole of the middle and the lower lobe of this lung with a massive shred sign. That's a massive pneumonia. Okay, now what is the fractal sign? So the fractal sign is basically an area of the lung that looks quite irregular. So when you look at this particular area of the lung, you can see, again, I can see a batwing sign. I can see pleura, and then in the middle, this area of the pleura is quite irregular, broken down. And this area that you see over here basically has a consolidation. The pleura is lost. You've got basically an area of tissue-like appearance with a very irregular margin near the pleural margin. This is classically what we call as a shred or a fractal sign. And again, is a sign of, I would say, mnemonic kind of a consolidation. It usually reflects an area of significant loss of lung tissue. And again, I would be very worried about an infective cause if that's the case. It can also be seen with meconium aspiration. And this is just another example of a fractal sign that you can see over here. It's more visible during expiration because the lung tends to kind of retract back. So again, I've got irregular pleura with an area of consolidation over here. And this is classical fractal sign, massive. It's massive. Look at this, all fractal sign. That lung is very destroyed. So shred sign is a good marker of a mnemonic kind of a consolidation. Bronchograms are important. There are two kinds. Don't worry, we will cover them again. But there are air and fluid bronchograms, and the presence of bronchograms that move in and out of the lung, dynamic bronchograms, along with shred sign in a tissued area, usually are indicative that you might have a mnemonic kind of a consolidation. So a very good example is, this is static air bronchograms. So what are they? They basically reflect areas of air that are trapped within tissue. So if we look at this, right upper lobe, no pleura. So air not entering this entire lobe because the tube is down the right main bronchus, but the small areas of air that are still trapped within. Now air is a good reflector. Because it's a good reflector, it will appear bright. Over here, what we've got is, we've got mnemonic consolidation, and we've actually got pus coming in and out of these bronchial trees. Now, this pus basically is dense, hyperechoic material, and hence it's giving a bright area, but it's exudate moving out of the tree. And this is a dynamic air bronchogram. Now, air trapped in this particular area, static air bronchogram, is commonly seen in collapse consolidation. But if you start seeing dynamic air bronchograms, or dynamic exudative bronchograms, which appear slightly darker, then really from our perspective, that tends to favor a mnemonic kind of a consolidation. I'm not going to cover atelectasis today, but this is just an example of a double lung point. Again, a lung that's slightly better aerated. So you can see that up here, we have a B profile, and actually the lower region of the lung is basically transitioning to an A profile. This is commonly seen in transient tachypnea of the newborn. And we've spoken about the lung point. This is the most beautiful image of a lung point that I've ever seen. So a lung point reflects the region of transition between the normal lung, which basically has got pleura that's moving in. There's no air, so the pleura can actually shimmer and move on itself. But over here, you have a pneumothorax. So actually, parietal visceral pleura have been kind of separated by air, naturally because air is a reflector. You see that there is no pleural sliding. And this basically reflects the zone at which normal lung is transitioning into a pneumothorax. It's called the lung point. Any question about these signs? Any questions? So what exactly is the lung point? Now, the lung point is a very important marker that you have to trace to try and quantify how large a pneumothorax might be. Now, why is it important? Is because this is basically a left-sided pneumothorax. You can see lung that is collapsing with expiration and expanding with inspiration. Now, as the air accumulates, if this is a tension pneumothorax, this will get larger and the lung will collapse completely. Now, your probe will basically be kept over here. This is the anterior part of the chest. Now, I want all of you to look at me. So I'm doing R1, I'm doing R2, I'm doing R3, R4, R5, R6. Now, we know that the air is anterior. So if I see an A' profile only in R1, that's a very small anterior pneumothorax. If I see it in R1, R2, that may be slightly larger anterior pneumothorax. But as the air accumulates and the lung collapses, air will move laterally. Alternatively, if the rent is lateral, then it will move anteriorly and the pneumothorax will get larger. So as I trace out, what I'll find is that I've got an A' profile R1, R2, A' profile R3, R4. And really, once I start crossing into the posterior axillary line, experience says we're in trouble. This is a pneumothorax that is large or getting worse and will need treatment. And that is why you need to trace the lung point, because really, at some point, the collapsed lung at the back of the chest, which is kind of between R5, R6, and R3, R4, will become visible. And you will be able to see sliding versus no sliding. So when you can see sliding, that's the point at which you've reached your lung point. Now, if you can see sliding in the anterior axillary line, and you only see an A' profile in R1, that's a very small pneumothorax. But on the other hand, if you start going backwards and you start seeing lung sliding right at the bottom in R5, 6, then that's air that's basically an A' profile all the way across your chest. Now that's quite a significant pneumothorax, and be surprised if your baby is not symptomatic. But you, for the diagnosis of a pneumothorax, have to always trace the lung point. You must be able to demonstrate it. Unless you have got a pneumothorax that is massive, that has caused the entire lung to collapse, as you can see over here. And if you have a pneumothorax that's caused the entire lung to collapse, then you're not going to get a lung point because there's no lung to actually expand. And I mean, this is a baby who we had a few years back where, I mean, we basically were doing this lung ultrasound as we were needling this baby because this baby had a massive tension pneumothorax. And really, I had the probe there, and we just kept the probe there to try and see if we're going to get a lung point back. But this was an A' profile. So what you can classically see is the bat sign, pleura that's not moving at all. You've got a truck sign, mirror image artifact with what is an A profile. There is absolutely no lung sliding, and this is what we could see all the way from the front to the back. So this is a very large pneumothorax. We're in trouble. My gut feeling is you should already have been clinically, but what you really need to then kind of look at is the barcode sign. And when you're looking for the lung point, it's the area that you transition from the seashore sign to the barcode sign that actually is also definitive. So if there's confusion, it can be quite confusing. So say, for example, if you're kind of in the situation where, is this sliding? Is there no sliding? Like if you look at this slide, it's quite confusing. I'm trying to figure out really where my lung point is, because actually the sliding is in quite a large region. So what I'll do is I'll go and I'll use my M mode. And if I can see the transition of the seashore to the stratosphere sign, then that is actually the region at which I've actually achieved my lung point. So in summary, for the diagnosis of a pneumothorax, really what is absolutely essential is that there is no lung sliding, that you have an A' profile, that you demonstrate a barcode sign on M mode, and that you then look for a lung point. Naturally, because you have air between the visceral and parietal layers of the pleura, you're not going to get any transmitted impulse. You may or may not have a truck sign or a mirror image artifact. Any questions about how you diagnose a pneumothorax before we move on to RDS? Anybody?
Yes, please. I have comment about lung point with severity of the pneumothorax.
Yeah, please.
Sometimes the should be looked at clinical. Sometimes the small rim of air around the lung. If in any point to do it, there is no lung point. Look clinically, the baby is okay.
Yeah.
But not necessarily don't follow lung point. It is severe tension pneumothorax.
Yeah, I've always emphasized clinically correlate. I've always emphasized that the spectrum, say a very big baby who does not have much lung disease. Can I give you an example? A spontaneous pneumothorax in a baby with no underlying lung disease. Really, that will take a large amount of air to even become symptomatic. We see moderate, pneumothoraces in babies sometimes that are picked up incidentally. The baby has no symptoms. On the other hand, if that is a baby who has transient tachypnea of the newborn with very severe kind of clinical presentation, as well as pulmonary hypertension, then a smaller amount of air may make that baby become symptomatic. So I agree with you that just demonstrating the lung point alone and its extent should not be used as a marker of the severity of air. You should clinically correlate. I completely agree with that point. But what I would say to you is that if you have a baby who's got respiratory distress, who is deteriorating, and you want to monitor whether this is getting worse, then actually if you had a lung point that was in the anterior axillary line that you can now see in the posterior axillary line, or if you kind of see this kind of a clinical presentation in all regions, we're in trouble. Now, ventilated babies, like, this is a baby who had a diaphragmatic hernia. Now, I really want to be 100% sure that I really need to put a drain in a baby with a congenital diaphragmatic hernia. So what I would say is clinically correlate. Absolutely. You have no symptoms. My recommendation to you would always be get a chest X-ray. where possible, while you're learning, until you develop the confidence. Because really, the risk of not getting a chest X-ray and blindly putting a drain in is, until you're really confident that you can demonstrate these signs, is it's not without risk. And hence, I'll be sharing a protocol with you that I've developed that helps to keep you safe during that process. Does that help?
Okay. Yes, thank you.
Okay, just very quickly about how we differentiate RDS and transient tachypnea of the newborn. Now, what is very important from my perspective is that respiratory distress syndrome and transient tachypnea of the newborn have spectrums. And what we must always realize is any baby between 22 and up to 40 weeks of gestation can have respiratory distress syndrome, uh, and also have retained lung fluid, which is gradually transitioning because the baby is either breathing at term versus a baby who's had surfactant in the delivery suite, who's more preterm. And we tend to get overlaps in this spectrum, both on chest X-ray, but also on lung ultrasound, which can make differentiation quite difficult. And that's why I would say to you that what is really important again is that you clinically correlate and you take your decisions based on the clinical presentation of the baby and its clinical course, as opposed to saying, I'm going to do a lung ultrasound at one point of time at 1 hour, and that will definitively tell me that this is RDS versus TTN. Now, you have to use what I would say is not just the lung ultrasound appearances, you have to use your clinical kind of approach, because whether you're using chest X-ray or lung ultrasound, the diagnosis of RDS in particular is still a clinical radiological diagnosis, unless you're using the shake test. Uh, what is also important is that both can coexist. You can have RDS with transient tachypnea because you have retained lung fluid at the start when the baby's born, which is getting better. Now, this baby is an infant of a diabetic mother. So naturally, at 36 weeks, this baby also has an element of surfactant deficiency. So you may have a complete whiteout appearance that then evolves into RDS because this baby's not getting better. So serial lung ultrasound may be needed to make that diagnosis. But if that's a baby in 50% who's got a complete whiteout appearance with air bronchograms, the question is, will I want to wait till I get the typical lung ultrasound appearances to treat? I might not. And I would say that clinical correlation is key. You can also have RDS with pneumonia. You might get a fractal sign with a consolidation in the posterior region in a baby who has RDS. So it's really important that you interpret your lung ultrasound very cautiously. The typical features of RDS, I would say, and this is a very big slide, but let's talk about the fact that often we know that more than 80% of babies, under 25 weeks will have an element of respiratory distress syndrome if they're not steroided. By about 28 weeks, if you're steroided, that's between 50 and 80%. 28 to 32 weeks, the incidence becomes even less. But really, when you look at lung ultrasounds, what you're describing is a very abnormal pleural line. It's thick. It's sometimes a little bit irregular. You can get this area of what we call as subpleural consolidations. Now, this is not typically described as a C or profile, as per Daniel Lichtenstein's classification. We call them subpleural. The reason they're subpleural is they tend to happen where you have surfactant deficiency because of hyaline membrane disease. So naturally, those areas of the lung, the distal areas, are less well aerated. They have atelectasis, the alveoli are collapsed. And because of that, you tend to get these subpleural areas of consolidation that you can see. If it's very severe, you don't have aeration, you lose your pleural line. And you have not just subpleural consolidations, but you also have atelectasis, where the pleural line is completely lost. And I mean, this is, I would say, severe enough to kind of present with consolidation. So this is just an increasing severity of how we classify respiratory distress syndrome. But really, the classical difference between respiratory distress syndrome and transient tachypnea of the newborn is the presence of subpleural consolidations. Hyaline membrane disease tends to cause alveolar atelectasis, lack of aeration, which then gives you this appearance of distal lack of aeration, which gives you subpleural consolidations. As opposed to transient tachypnea of the newborn, where really what you're going to see is, I would say, My apologies, went to the case too early. This kind of an appearance where you've got a relatively blurred pleural line. It's abnormal still, maybe thin or thick, but it's relatively uniform, continuous. You've got predominantly an interstitial pathology here. The alveoli may have fluid, but the interstitial space has a lot of fluid, which the lymphatics and the pulmonary venous circulation needs to drain. So really what you may have in the early phase is a whiteout, AIS. This is compact AIS. You may have a complete whiteout. You may have an element of a pleural effusion with a complete whiteout of the lung. Or as the baby improves, you might get these areas of Dougal lung point, which is aerated lung, side by side, B profile, AIS, white lung profile. And as the baby gets better, you'll gradually transition into a baby who's got a dominant A profile. But you will not have subpleural consolidations. We're going to cover RDS and TTN as individual pathologies in more detail. I will teach you how to classify it, classify severity, how we would manage babies based on this. But in essence, if I summarize, because we have finished 90 minutes exactly now, we have discussed a revision of lung signs, normal. We have discussed abnormal in terms of what the different lung profiles represent and how we would like to describe them. And we have ended by covering 3 pathologies today: pneumothorax, RDS, and transient tachypnea of the newborn. My expectation is that by the end of this course, you become proficient and competent at being able to diagnose pneumothorax, RDS, TTN, have good proficiency in diagnosing pleural effusions, pneumonia, meconium aspiration. And for those of you keeping logbooks, the expectation is 25 scans, 50% of them should have pathology. And I would expect that you have done or imaged at least once all these 6 pathologies that I've just described. I do not expect you to necessarily have features of atelectasis. It can be tricky to interpret that, nor do I expect that at an L2, L3 level, which you achieve, that you can confidently differentiate the two, but we will cover it in a lot of detail. Any questions?
Yes, please. About shared sign.
Yeah.
There's other pathology. Can you have shared sign like pulmonary hemorrhage or aspiration syndrome?
Yes, very much so. I mentioned that you can see it in meconium aspiration. Early on in pulmonary hemorrhage, when your alveoli are basically full of blood, you may not see it. But later on, I would say that the inflammatory reactive cytokine release that happens with pulmonary hemorrhage can cause alveolar destruction, and because of that, you can see a shred sign in that situation as well. So it's not pathognomonic for pneumonia, but what I'd say to you is that you really have to clinically correlate. If this is a baby who is suddenly has a rising FiO2 in a situation where you've got temperature instability, there is underlying Klebsiella on ET secretions that you've previously colonized, and you get an appearance that shows a shred sign, as I've kind of shown to you. You'd be very brave not to cover with antibiotics. And common being common, I think that's pneumonia, as opposed to kind of thinking about meconium aspiration versus a baby who's just been delivered through thick meconium, who's got changes of consolidation. We'll show you meconium tomorrow, but where you have a shred sign at birth. Now, it could still be infective. Most of those babies will get antibiotics, but actually, really from your perspective, if it's patchy rather than being uniform, then you have
Yes.
meconium. It could reflect meconium aspiration as well. Any other questions? No other questions?
I have.
Yeah, please.
Can you hear me?
I can hear you.
Dialogue. Tell me, please, about again pleural effusion. Is it a distance between 2 lines of pleural, or no? And if yes, what is the differentiation between hydrothorax, for example, and small hydrothorax, and pleural effusion?
So my personal view is I don't use the word hydrothorax. because it's a very vague terminology. I know that they're used interchangeably, at least in the UK. But what I'd say is that pleural effusion would be fluid between the visceral and parietal pleura. And really what you'd be able to see is what you call as a jellyfish sign. Again, from my perspective, really there'll be an element of lung atelectasis because the lung is compressed. So an effusion would always be fluid between the visceral and parietal pleura.
Thank you.
Yeah, hydrothorax would be used interchangeably in the UK to describe that. I don't tend to use that terminology. Any other questions before we finish?
Yes, Dr. Alok, about the hydrothorax and the pleural effusion. If this is a lymphatic hernia repaired, the lung is
Very good.
and still hypoplastic.
Very good. Very good. Yeah.
It is
So,
will be a secretion from the intestine. It's not between pleura.
yeah, so you're right. Again, that's why I would say that I tend not to use the word hydrothorax. So if you've got a congenital diaphragmatic hernia that's been repaired, often the bowel's been pushed down, really lung is collapsed and is gradually getting recruited. So the fluid that then accumulates in that particular area, would be very different, but may actually present very similar to the way an effusion presents. So there are slight, I would say, differences. For me, what is very important, again, is really that you're looking at the underlying diagnosis and the clinical course, because naturally, if I see an effusion accumulating after a diaphragmatic hernia repair, naturally, I'm not going to tap that unless, in my career, probably once only have I ever tapped it. So really the question is if the baby's completely stable, I wouldn't be doing a lung ultrasound anyway. But if I did a lung ultrasound because the baby was deteriorating and I found an element of effusion in that area with a diaphragmatic hernia, logic would say that that's post-operative collection.
Yes.
Any other questions? So we're going to stop today. Just very quickly, I just want to say that after tomorrow, the sessions are no longer didactic. So the intention from our perspective is we start workshops pretty much from Thursday onwards, where there'll be a lot of interaction from you. We have peer review sessions every Thursday for those of you who want them. They're perfectly optional. You don't have to attend if you don't want to. You can watch them in your own time. I would strongly urge that for those of you who want peer review, that you record images and we share them. It's the best way to learn. But this, in essence, completes today's session. Thank you very much.
Thank you, Al.
Thank
Thank you.
you.
Thank you.
Thank
God
you.
bless you all.
Thank you. Thank you.
Thanks, Alok. Cheers.
Thanks.